This is a case of diverticular poem in a patient with large epiphrenic diverticulum. A 55-year-old male presented with difficulty swallowing both liquids and solids since past 3 years with significant regurgitation. Manometry shows presence of achalasia cardia. On initial endoscopy, there is a large epiphrenic diverticula measuring around 5 to 6 cm with the proximal esophagus showing sigmoid type morphology. Following, the barium shows a significant retention of contrast. The usual steps of poem, that is submucosal injection, mucosal incision, and tunnel entry was done. Careful dissections of submucosal fiber by fiber. Intermittently, we visualize the orientation of the tunnel because of the sigmoid morphology. The submucosal dissection is continued. But upon reaching the G junction, we could not visualize the septum, so we went again and we realized that the tunneling has went spirally and now the submucosal bleb is anterior to the diverticulum. So some lateral dissection was initiated at the level of diverticulum and we finally established the normal axis of tunneling. We also encountered multiple large collaterals. There was a particular large collateral sitting on the septum of the diverticulum, so it was carefully isolated and coagulated with the help of co-grasping forceps. Dissections on both the sides of the septum was completed and we could isolate a thick septum in between. Upon retracting the scope from the lower esophageal sphincter, the cap got dislodged and got firmly stuck at the level of LES. In spite of multiple attempts to remove the cap, which got failed, I had to finally do some local myotomy at the level of cap to visualize it. Muscle fibers below the cap were also dissected gradually, and with the help of grasping forceps, the cap was pulled and removed. Now further submucosal dissection was done and we assured that the dissection is completed 3 cm beyond the G junction. The proximal myotomy was started with an intent to extend the myotomy and join the previously done myotomy. However, we encountered a large bleeding vessel and the endoscopic view was completely obscured. Upon aggressive flushing, we could identify the bleeder and with the help of co-grasper forceps, the hemostasis was achieved. Further myotomy was continued. Now the septum was carefully dissected gradually, keeping care of any collaterals because collaterals can be encountered in these thick septums. The myotomy of the septum was completed till the base. Now the lower esophageal sphincter myotomy was completed with the help of IT knife so as to keep the mucosa safe and prevent it from any injury. Finally, the tunnel was examined and now we can appreciate that there is complete flattening of the septum and the negotiation across the LES is quite smooth. The mucosal incision was closed in a usual manner with the help of multiple hemoclips. Post-poem contrast study shows no leak with swift and easy passage of contrast into the stomach and almost complete emptying of the diverticulum. Thank you.